Well, hello there, and welcome back to Pandemic Radio. This is part two of our exciting journey into the epidemiology of the spread of the COVID-19 pandemic. We stopped last time at this concept of surveillance bias. We had been talking about basically the epidemiology tools that are uh, available to us to count the number of cases of disease. So we come up with a case definition. We say this is a set of criteria that need to be met in order for someone to be counted as a case or not. Um, and like many things in public health and epidemiology, it is prone to some error and some uncertainty, uh, which is also known as bias. Um, when we're trying to count up and measure things that happen in human populations, it's very, very difficult to get an exact true number of anything. Even like the number of people that, live in the state of California, very, very difficult to know that exact number at any given time. So usually we just end up coming up with our best estimate. So disease surveillance has a few different steps that it needs to take. And each step along the way can potentially introduce uncertainty. So, bias or uncertainty is basically another way of saying uh, not reality. So, um, it is all that stuff that blurs our true understanding of the actual number of cases of disease. So, it starts off with, the detection and uh, notification that an event is happening, then followed by basically going around and counting everyone up. Then, when the data starts coming in, you analyze it, you interpret the findings, and then you hopefully go do something about it. So these are the kind of steps that occur in disease surveillance. So public health surveillance systems have existed uh, for a long time. This is not new to COVID-19. And the steps that we're kind of concerned with at this point is really focused around the identifying and counting the number of cases of COVID-19, for example. But again, the thing about doing this is it's not perfect. Um, the example I like to give is related to the 2011 Fukushima nuclear disaster. If you're not familiar with this, a large earthquake sparked a large tidal wave to hit the coast of Japan, and this ended up striking a region of Japan that had a nuclear power plant. And this ended up basically knocking out the power and causing an explosion. This explosion led to a large release of radioactive material. And this concerned a lot of people because radioactive material is not great for human health. It's actually really bad for human health, and it's particularly bad for kids when it comes to thyroid cancer. Uh, this exposure to radiation can lead to an increased risk of thyroid cancer in children. So, naturally, scientists and epidemiologists were concerned that there was going to be an increase in the number of thyroid cancer cases in children around the area because of this disaster. There's nothing wrong with that. It's perfectly logical to assume that. So the authorities set out to, they basically launched a big surveillance program to go out and screen over 300,000 new residents of the area who are under the age of 18. And they used the most advanced ultrasound devices that they had available to them. So they basically went out and counted every single person they could, and they tried to detect this thyroid cancer using the most advanced detection methods they had available to them. And not surprisingly, they found that there was a large uh, spike in the number of thyroid cancer detections in this area. They found that the event, the disaster, was associated with this big spike in cases. And when word of this got out, it made a lot of people really scared, really angry, and it fueled this concern over nuclear energy, because of this surveillance effort. They found that there was a 30 times increased risk of thyroid cancer compared to normal. So they found this big spike in cases. But some people started to question this finding because it seemed to represent a pretty clear case of surveillance bias. And what I mean by that is, was this actually an event that truly raised the number of thyroid cancer cases? Or was the big spike that we saw simply a matter of we were testing more? So, was it that the disease was actually occurring more, or were we just looking for it more? And of course, if we look for something more, we're going to find it. So, to test for this, they went around and they tested children from outside the area that was exposed to radiation. And they used the same rigorous approach with the same fancy uh, medical equipment. And they found that actually, when they looked other places really carefully, they also found a higher number of thyroid cancer cases. So it wasn't the fact that the kids were exposed to this accident, it was just because they happened to be looking for it more. This is an example of surveillance bias. When you look at one group or you try to count disease in one group differently than another group, uh, you are artificially creating trends in the data that do not relate to the natural spread of the disease. So, the thing about public health surveillance is that it's not perfect. We need to be aware that surveillance bias exists so that we can interpret findings in a meaningful and logical way. And we see this with COVID-19. Uh, a very real concern is when we look at the interpretation of trends and data. For example, uh, are cases actually increasing in the United States? Or is it because we are testing more? And that's a logical question to ask, because uh, if we are just testing more people, we're going to be finding more disease. That's just uh, how statistics works. Um, but what we're seeing is actually trends in the number of disease cases are a lot greater than what we would expect to see due to just surveillance. So we do expect there to be an increase in the number of cases we detect because we're doing more and more testing now than ever. But what we're actually finding is that the number of diagnosed COVID cases is much greater than what we would expect just due to the increased testing. What this indicates is disease is actually spreading. Incidence rates are actually increasing, and it's not just because we're testing more. So when a disease like COVID rampages through a population that has never encountered it before, it is a new virus. Uh, Everyone theoretically is susceptible. This is a concept called herd immunity. Uh, when a vaccine exists, like with influenza season, and maybe some people have been exposed to the flu, maybe some people have received the flu shot, uh, there is a higher level of population immunity to a disease. So, what that looks like is when you're dealing with an infectious disease and it is spread from person to person, um, if there is no herd immunity, if everyone is susceptible to the disease in the population and I'm infected, theoretically, anyone I come into contact with can become infected too. And then they can go and spread it to anyone they come into contact with. And you see a really quick spread of disease. And this occurs when nobody's vaccinated and everybody is susceptible. When some people are either vaccinated or uh, they are no longer susceptible because maybe they recovered from COVID and they have some immunity built up, uh, there is less opportunity for the virus to spread. So you don't see the kind of large scale spreading events. Uh, we see more kind of slower progression. And herd immunity is achieved when enough people in the population are either vaccinated or immune. You basically run out of places for the virus to spread. So I kind of think of this like a wildfire example. So if you have a large field full of like dry brush, uh, and you have a little spark starting on one end of the field, and it starts to spread, there's nothing really to stop it from just spreading throughout the whole field. But if you put down like fire retardant or dig fire breaks in the field, you have basically blocked the amount of fuel that the fire could potentially get, so it doesn't spread as much. So basically, herd immunity has to do with how many people are susceptible, which dictates how quickly a disease like this will occur. And this is why vaccines are so important, because vaccines are a great way to achieve herd immunity, meaning enough people are vaccinated that the virus basically stops running into people that it can spread to and it dies out. We can see examples of this in history of public health. So, measles was a very serious disease in the United States in the early 1900s, and a really good vaccine was introduced, which caused cases to plummet because a lot of people got vaccinated, and basically the disease, the pathogen had nowhere to go. If no one was susceptible anymore, it would stop spreading. Recently, because of anti-vaccination uh, beliefs, we have seen some outbreaks. But in general, this is an example of herd immunity against this disease. So we are currently on this so-called journey to herd immunity when it comes to COVID-19. We have a virus that is brand new. meaning that no one has immunity to it, and there's really nothing to stop it from spreading to everyone, uh, theoretically. Uh, those who have been infected and who recover, um, evidence is showing that at least for a little while they have some immunity, which means that if they encounter the virus again, they will not get infected. So there is a little bit of immunity built up in the population, but not enough to spread to stop the spread. Herd immunity for COVID-19 uh, is achieved when roughly 55 to 82%, I've seen safe estimates above 70% of the population needs to be immune. The only way that this is logistically going to happen is a vaccine. So you may have heard some stories or read some stories about some countries wanting to like achieve herd immunity naturally. So they want like the virus to kind of spread around and get a lot of people infected so that they will recover and then they will not be susceptible anymore. But when you're talking about a percentage that needs to be reached for herd immunity of 70 to 80%, if you apply that logic to the United States, that's hundreds of millions of people that would need to become infected and recover in order for herd immunity to be achieved. So if you look at what that looks like in some major cities, uh, the circle on the top left is what herd immunity uh, needs to look like. So if every little dot there is like a person in the population, the dots that are colored are immune, so they have antibodies, and the dots that are gray are susceptible. So that's what herd immunity looks like. And so if the virus basically runs out of room to spread, here's what our level of immunity looks like in other major cities. So this is why the virus is still spreading and increasing in a lot of areas, because just not enough people are immune. And really, the best way to increase those numbers and to boost that immunity is through a vaccine. So we need to know about herd immunity when we are measuring the spread of the disease. And a big part of measuring the spread is understanding how fast it moves and how contagious it is. And we can sum that up with this handy dandy little number, the basic reproductive number, aka the R naught, stars of such films as Contagion, and a useful tool to measure how quickly a disease is spreading. Here's how the R naught works. The basic idea is that, let's say I contract a disease and I end up passing it to 2 people. That would be an R naught of 2. For every person who is infected, it is the number of infections they end up causing. The number of people who end up becoming infected because of contact with them. So how you measure the R naught in a community, or like the R naught for COVID-19, is you basically just add up everyone's R naughts and you produce an average number. So some people get infected and end up passing it maybe to 1 person. Some people end up passing it to 2 people. Some people, they're called super spreaders, can pass it to like 30 people. But on average, you get a number that is closer to like 3 to 5. Uh, a lot of things can change that. How quickly the virus is spreading around, and we'll talk about that in a second. But the higher the R naught, the faster it spreads. So if there's an R naught of 2, then I give it to 2 people, and then each of those people gives it to 2 people. and so on and so on. And so you see with this graphic that an R naught of two, starting with just one person, you just in a few steps, you can see how quickly it grows. And diseases have different R naughts because some diseases are more contagious than others. So, hepatitis C, Ebola, HIV are on the lower end, and they have R naughts of 2 and 4. Uh, these diseases, a big reason for that is because they require close uh, contact. So, contact with blood or through sexual transmission. Um, and diseases that are more respiratory, spread through the air, tend to be more contagious. So, the most contagious disease that we know about is measles. It has an R naught of 18, and that means for every person who's infected, 18 will contract the disease. Kind of scary. But uh, this can change given how susceptible or how much herd immunity is built up in the population. So let's say that a disease like the measles that has an R naught of 18 uh, starts to spread in a community. Let's say half the community was vaccinated against measles. So half the population is immune and cannot contract the disease. So actually, the effective reproduction rate is 9. So this number obviously will go down when more of the population is immunized. So that's why you want more people to get vaccinated because it drives this number down. This is how you essentially calculate herd immunity. So isn't that kind of fun? So for a disease outbreak to stop, for a disease to die out, this is the level of herd immunity that you need. So a disease like the measles with an R naught between 12 and up to 18, you need herd immunity of up to 94, 95%. Okay. So this is why just having a few people uh, have anti-vaccination beliefs and be unwilling to vaccinate chips away at that. And if maybe 95% of the community is vaccinated, but then a few dozen people want to stop vaccinating, then maybe you drop that herd immunity level down to like 92 or 91%. That's enough to lose the effect and have an outbreak. So again, we are still learning and understanding what that magic number is for COVID-19, um, but it's probably somewhere around at least 70, if not more, percent. Flatten the curve, we have heard about because this is why we are doing things online. This is why shelter in place orders were put in place. This is why a large part of the population was mandated to basically stay indoors and stay away from others. It was to flatten the curve. So, what does that mean in epidemiology terms? A big part of it has to do with this term called surge capacity, meaning uh, when a lot of people get sick all at once, for example, with a disease like COVID that aggressively attacks your respiratory system, then a lot of people all of a sudden, all at once, require uh, medical resources like ventilators. And we don't just have millions of ventilators kind of just lying around. There's a certain number of them. There's a certain number of people trained in using them. There's a certain number of hospital beds. And if everyone got sick and needed them all at once, this is like a big tidal wave or like a surge. And the ability for medical systems to withstand that is the surge capacity issue. So when the tidal wave of patients is bigger than the supplies that a healthcare system has, um, then surge capacity has been reached, and you have really serious issues and really difficult decisions need to be made. For example, who gets a ventilator when you only have one left, but like four people need it? Who do you give it to? So these are the kind of issues that were um, tried where the curve flattening was really kind of attempting to prevent. And you guys have probably all seen graphs, maybe not the murder hornet deaths graph, but something like this, where you have two different kind of curves. One representing what happens if we don't do anything. What one happens if we all shelter in place, like good public health citizens. But on a side note, whatever happened to those murder hornets? Anybody know? Let me know. So here's a real graph from the CDC. So the x-axis, the one going across the screen on the bottom, time since the first case, is time. So you start from the beginning of the outbreak and onward. The y-axis, the up and down, is just the number of cases. So these are epidemic curves. The dashed line across the graph is the capacity for that the healthcare system can basically take on. So if a system had 30 ventilators, then that number would be uh, having to do with that. And you can see what happens when you have an outbreak that is spreading in a population with no herd immunity. So there's nothing really to stop it from just spreading very, very quickly. You see very quickly the healthcare system becomes overwhelmed because all of a sudden, way more people need those ventilators than we have. And this causes really difficult issues. So the idea with flattening the curve is not to necessarily cure or stop the disease altogether, but really to kind of slow it down. So you don't get the huge initial steep peak, but more of a slower, gradual increase in the number of cases. You're trying to slow the spread of the disease. So not everyone rushes into the hospital all at once seeking medical care. And this gives the healthcare system basically time to kind of keep up with the demand. And this was the whole idea behind flattening the curve. What also was an issue during this time was trying to increase that capacity. So, trying to increase surge capacity while also flattening the curve. So, if you saw news reports about some companies switching all of their resources into making more ventilators or making more N95 masks, etc. Some countries were building a lot of extra makeshift hospital beds, things like that. They are trying to raise that dashed horizontal line, to try to prevent surge capacity from being breached. And if that didn't kind of maybe make sense to some people or whatever, I just thought this was kind of a fun example of how you can make this kind of thing relatable to everyone. Because maybe not everyone likes to hear about epidemic curves and surge capacity and this and that, but a lot of people like cats. So if you're trying to remember the whole concept behind the flattening the curve thing, just remember of cattening the curve, uh, where in one scenario you have an alert kitty outbreak, which will pounce and shred the healthcare system like the arm on your couch. Or you have a more lazy kitty, where long intervals between transmission events occur, like the amount of time kitty will hold this position. Healthcare systems can cope. So we want a lazy, lying down kitty, not an alert, about to pounce on you kitty. Cattening the curve. And who said you can't have a little fun when talking about the epidemiology of a pandemic? So that's it for the epidemiology of COVID 19. Well, that's it for the very brief introduction to some of the principles. Um, for more about the spread, read the articles, enjoy the other lectures posted, and let us know if you have any questions. This is Dr. Bales signing off.